This week on the BackTable podcast.
So if you look at the literature, the downstaging to resectability rates range widely from 10% to more than 50%. And the devil's in the details. You have to look very carefully at what the inclusion criteria were. But I think if you look at the NCCN criteria and look at studies that really stuck to those criteria, I think the number with optimal chemotherapy is probably sitting in that range of 20 to 30% for locally advanced disease. And for borderline disease, it's much higher.
Welcome, everyone, to BackTable Tumor Board. Today, we're going to be talking about locally advanced unresectable pancreatic cancer. My name is Zach Berman. I'm an interventional radiologist at UC San Diego, and I'm joined by my esteemed colleagues.
I'm Rebekah White, or Rebekah White. I'm a surgical oncologist also at UC San Diego.
And my name's Michael Sherer. I'm a radiation oncologist and the head of our GI radiation oncology section.
Fantastic. Well, I'm so glad to be joined by you guys. I think we have a very exciting conversation to have. This is a very complex and ever-evolving landscape for these patients. So I think a good place to start is maybe let's talk about definitions. What is the definition of locally advanced pancreatic cancer?
So before I answer that, I think it's important to talk about why we even have a definition. I think one is to set expectations for patients at the start of treatment, and the other is that for trials that we have a common language so we're comparing apples to apples. So I think it depends on which setting you're talking about, but I think generally speaking, locally advanced means that it's a tumor that, of course, is not metastatic as far as we know, but is not amenable to surgical resection. But as I know we're going to talk about, there's a lot of subjectivity in terms of what is resectable. And so therefore we have some very strict definitions about how we define locally advanced.
Yeah, and I think we usually start with NCCN criteria, which are based on vascular involvement. So anything greater than 180-degree arterial involvement would be unresectable. But then, as you pointed out, you get into a lot of interesting nuance. For example, venous involvement, just unreconstructible venous involvement, and what that means may be very different to different institutions and even different surgeons.
So it seems like the artery is the most important. So, as far as we know, does the venous involvement have any determination in that as well, or?
So, they're arguably both very important. I think for me, there are situations where I feel like vein involvement is no way, never going to be resectable. So, for example, when you have a complete vein occlusion that is long segment, there's thrombosis, like that's a situation that I feel is sort of permanently locally advanced, and I think you should set patient expectations appropriately. And likewise with arterial involvement, it's not just about the circumference; it's also about the length of that involvement, how dense and thick that involvement is, and whether you're seeing extension into the branches of those arteries. And so likewise, there are situations where you can assess a patient and really have a feeling that they are permanently locally advanced, and you should maybe pursue more palliative measures.
One thing that's been interesting from our tumor board discussions, I've learned a lot, talking about the relationship, especially with the veins, to like the draining branches and sort of what's needed above and below in order to be reconstructible.
Right. I think there is some growing appetite for doing complex arterial resections, especially in the era of effective systemic therapy, and so there's more discussion of how you define what are proper proximal and distal targets for reconstruction in our field.
So speaking about the tumor board discussion that we just had, I sit in the same tumor board as you guys, and I'm just a novice, and I have no idea the magic you guys do in the operating room. But I hear the terms borderline resectable and locally advanced kind of thrown around very similarly. What's the difference between those?
Right, absolutely. Obviously there's a continuum, and so by the NCCN criteria, borderline means for the artery that you have between 0 to 180 degrees of arterial abutment. For the vein, it means that you have greater than 180 degrees of involvement, but it is technically reconstructible. So we do have these criteria, but That being said, there's borderline and there's borderline. So you're right. In our tumor board, we have these discussions, but that's just referring to the anatomy. Then there are also there's a concept of being biologically borderline resectable as well, and that's I think probably more important than any of the anatomy that we've discussed.
And I think that distinction is very important, like you were mentioning, for clinical trial enrollment. But from a sort of practical standard of care perspective, borderline versus locally advanced, you usually start treatment the same way, with induction systemic therapy. So
I think that's a really important point, because I think at the time of diagnosis, you could argue that these distinctions are a little bit less important,
right,
because most patients are going to get neoadjuvant therapy, and other than defining their eligibility for trials and maybe setting some expectations, the precise definition of resectability maybe isn't critical. At the end of systemic therapy is when it becomes really important to define resectability.
So I think that's a good place to kind of kick off. So let's say we have a borderline patient, or maybe locally advanced, we don't know yet. What's kind of the normal pathway for that type of patient?
Well, they will see usually everybody up front, surgical oncology, medical oncology for sure, and then be presented in our tumor board. So we have a dedicated pancreas tumor board, and we'll look at the imaging with radiology and the talk. And, outside of a clinical trial, I think the main question that usually comes up is, are they a good candidate for chemotherapy? If so, what type of chemotherapy are we going to use as that induction strategy?
Could you briefly talk about the different types of chemo regimens, at least in 2026?
Yeah, so the two main options, modified FOLFIRINOX, so 3 drugs, 5-FU, oxaliplatin, irinotecan, versus gemcitabine and Abraxane. That's usually the initial decision point. And at least to my degree of understanding, for younger, fitter patients, we generally prefer FOLFIRINOX when we think they can handle it. But Gem-Abraxane is also an excellent option with good response rates.
Well, you were talking earlier about what the patient should expect, right? And so if you have these locally advanced patients, what percentage of them do you think are downstage to resectability, either borderline or locally advanced?
Right. So it really depends on the criteria, the inclusion criteria for the study. So if you look at the literature, the downstaging to resectability rates range widely from 10% to more than 50%. And the devil's in the details. You have to look very carefully at what the inclusion criteria were. But I think if you look at the NCCN criteria and look at studies that really stuck to those criteria, I think the number with optimal chemotherapy is probably sitting in that range of 20 to 30% for locally advanced disease. And for borderline disease, it's much higher. It's probably more like 70%, for example, if you look at the SWOG randomized trial of FOLFIRINOX versus Gem-Abraxane. So very, very different.
Mm-hmm. Yeah. And so at our tumor board, do we rely on the NCCN guidelines? Is it institutional criteria that we have, or some blend?
I think our institution sort of is very well acquainted with the NCCN criteria, so I think we do use those when we're talking in conference and in our notes. But then I think we add on to that the discussion of their biology and their fitness. I mean, I think these are really important things in our tumor board.
And the response to the neoadjuvant therapy, I feel like that drives a lot of the decision making as much as the anatomy. There's people who, they had a huge tumor, but it really shrunk. And yeah, maybe it's still, borderline versus locally advanced, but the 19.9 has come way down. And I think we tend to be more aggressive surgically in those patients versus somebody with the same exact tumor, but they had no response to the chemo. And that we might, head more towards a radiation or other local therapy pathway.
Obviously, there's radiologic response. You can use whatever criteria you want, like RECIST or whatever. But how else do we measure the tumor biology? You briefly mentioned CA19-9. I don't know if you want to explain a little bit about that.
Yeah, so CA19-9 is a tumor marker that's often elevated in pancreatic cancer. It's checked at diagnosis universally. Ideally, after any biliary stenting or intervention has been done, because that will also elevate your CA19-9. But yeah, values in the hundreds or thousands are very concerning for micrometastatic disease. And so, yeah, if we can get that down with induction systemic therapy, that's a good sign in terms of the disease hopefully being localized to the primary tumor site and therefore a good candidate for curative intent surgery. There are patients who never have an elevated 19-9 to begin with. It's far from perfect. So if you have it and you can follow it, it's nice, but sometimes you just have to make judgments off other things.
I think I'd like to pick up on the radiographic response question. It's really important to emphasize that we usually do not get any radiographic response in pancreatic cancer. And so we rarely even talk about RECIST criteria because we don't usually meet that, I think 20%, decrease in diameter. We're lucky to see any shrinkage. And if we do, we're ecstatic. So usually with my patients, I try to prepare them that radiographic stability is good and that it's going to underestimate their pathologic response. And so that's why we have to rely so much on the biomarkers like CA19-9. I do, especially if someone is a CA19-9 non-expressor, which is about 10 to 20% of patients. I will also check CEA. And, I think in the future, we're probably going to see more circulating tumor DNA, but that's, I don't know if that's quite ready for prime time yet.
Yeah, that's a great point about the radiographic response. The other thing, it's and especially after radiation, it's tough to tell what is a radiographic response. There's fibrosis, you see dark tissue up along the artery. Is that dead? Is that live tumor? Mm-hmm. It's often really difficult to tell. So I agree about counseling patients that, even with neoadjuvant therapy, it's rare to see sort of clear regression of the tumor.
Besides just that initial, let's say, CT scan when they were diagnosed, what other sorts of imaging do we use as far as workup? Is like a PET CT involved at all in any of this, MRIs, et cetera?
Yeah, MRIs can be helpful as kind of a complement. The CT scan, if you haven't already had one, we'll get a dedicated pancreas-protocol CT because the different vascular contrast phases can really help tease out what vessels are involved or not. An MRI going along with that, I think, is often helpful. You can look at like diffusion restriction to try and get a sense of the size of the tumor. PET scans we'll use occasionally. Sometimes if there's especially like an indeterminate finding for metastatic disease in the lung or the liver, we'll get a PET scan to further work that up. PET scans, I don't find super helpful for determining like vascular extent of the local disease. Another thing that we as radiation oncologists care a lot about is like bowel involvement, right? Is into the duodenum, and can be physiologic PET uptake in the duodenum. So a lot of times you're not really getting much from a PET scan about the primary tumor site.
I agree with that. I don't use PET routinely. I think one thing about MRIs is that I do find them to be more sensitive for small liver lesions than CT scan. And so I think especially if you have a patient that has a very high CA19-9s out of proportion to their tumor size and you're looking for an explanation, that's when I'll get an MRI, especially if I'm nervous about operating on someone and looking for a reason not to. Getting an MRI will often find more than the CT does.
Yeah, when we get those MRIs, though, we frequently see the indeterminate liver lesion, right? So how do we manage that?
Well, you guys are so good at biopsying them.
Yeah, that's right.
It's like 2 millimeters. You guys can get it.
No problem.
Yeah.
Well, I think the best thing for an indeterminate liver lesion is the test of time. So I think depending on where you are in your treatment course, if it's the beginning of your neoadjuvant ramp, you'll you just watch it. If you're at the end of your neoadjuvant runway, it's trickier. I think sometimes we will, sometimes we can do it. You can do a staging laparoscopy, for example, and try to find it or look for some other lesions. Or sometimes that's when we'll insert a period of chemoradiation to give that lesion a test of time.
Gave a lot to think about there. So let's start with the first one, the staging laparoscopy. How often are you using a staging laparoscopy? Is it 100% of patients you're thinking might go to surgery?
So I would say 100% of patients who undergo surgery will end up with a staging laparoscopy. The issue is when. So, you could argue that we should do staging laparoscopy on every patient before you start neoadjuvant therapy. But, it's not really practical, I think, from a resource standpoint, and I don't think it often will not change your first line of treatment. So I will do it if it's going to make a difference to the patient. So if you have a patient who's really apprehensive about getting strong chemotherapy, for example, and you have some suspicion that they might have metastatic disease that's not seen on imaging, sometimes I will offer that to help them with their decision-making. Otherwise, I wait and I do it right before surgery usually under the same anesthetic, sometimes as a separate procedure.
And I think that gives us a nice kind of segue from the diagnosis to the treatment. So let's say the patient has made it through their induction chemotherapy. We're kind of in that indeterminate stage right now where we're still kind of borderline whether or not they can undergo a full surgical resection. I guess I'll start with you. What options do we have for that patient?
Yeah, so radiation, of course, I'm going to jump to. We do think about in that situation, both as Dr. White was saying, as a test of time. One of the principles of neoadjuvant therapy that we've talked about a lot is to downstage the tumor as much as we can, make it more resectable. The other one is to identify patients who have, unfortunately, very aggressive disease, who are going to metastasize and would not benefit from going through a Whipple or other major surgery. And so chemoradiation gives you a window to continue treatment of the primary tumor, maybe get some more regression of the tumor, maybe help achieve a margin negative resection. There's some data for that. And also test the tumor biology and give it a longer sense for those indeterminate liver lesions to declare themselves one way or the other. Another thing that we will do sometimes is switch chemos, right? So if they've been on FOLFIRINOX, some response, but not great, or they're not tolerating that well, maybe try Gemabraxane or vice versa, if you think you can handle it. Those, I think, are sort of the two main standard of care options that we have for trying to extend out that neoadjuvant therapy as long as we can.
So for the less knowledgeable people like myself, can you explain what chemoradiation is?
Yeah, so radiation treatment to the pancreas, we'll definitely get into this. There's a few different ways to do it, but the one that's been used for the longest, specifically in the pre-op setting, is radiation 5 days a week for about 5 weeks. And so that is breaking up your total radiation dose into lots of small little pieces, which we think is a little gentler on the surrounding normal tissue. And so it's given with radiosensitizing chemotherapy, typically Xeloda in the United States, although there is some data with gemcitabine, especially from Europe. But we almost always use Xeloda. And we treat the tumor and then a small margin sort of along the involved vasculature with focused radiation, with the goal, obviously, of, sterilizing, especially right along the margins where the surgery is going to be the most difficult. And it's a pretty well-tolerated treatment. I mean, people, I would say, usually report fewer side effects than relative to the IV portion of their chemotherapy. You can definitely have some fatigue. You can definitely have some nausea, some diarrhea. But on the whole, people do pretty well with it.
And then let's say they get radiation. I know it can potentially affect surgery down the line. So how do you balance radiation and surgery?
Yeah, so there's a temporal effect after radiation where you have some acute inflammation, and then there's a window where that acute inflammation subsides before you get into some of the more chronic fibrosis. And I think most of us in our field believe that window is probably somewhere between 4 to 8 weeks. And if you operate on someone more than 8 weeks out from radiation, it can be pretty hostile. Mm-hmm. So I think that's why we like to, if we're going to insert radiation into our neoadjuvant scheme, we want to sequence it last, and then coordinate with our radiation oncologist so that we time the surgery appropriately.
Yeah. And so let's say you switch your chemotherapies, you still have stable disease, you get chemoradiation therapy or any other form of radiation therapy. What are you expecting to see at the, let's say, 1 month scan? Stable disease, is that considered a win? And then you just go straight to the OR? Or?
I think Dr. Sherer will agree that, especially with radiation, we often do not see shrinkage, and we are happy to see stability. We know that will probably underestimate our pathologic response, especially with radiation.
Yeah.
And so we often use the phrase, give them the benefit of the doubt. This is, I think, a phrase we use a lot in the setting of borderline and locally advanced disease, where we still see there's still some tissue abutting the artery, but it's been treated with radiation. Perhaps the tumor markers have normalized. That's a situation where sometimes we will explore with the idea that we're going to give them the benefit of the doubt.
Let's say we do all of this, you still have the vascular involvement. At certain select centers that have high volumes, would you argue that we're not being aggressive enough with our arterial resections, arterial reconstructions? I know we've been involved in, some complex like celiac artery resections and stuff like that. Or would you say we're still trying to figure that out? And
I think we're still trying to figure it out. I think that I think some people are perhaps being too aggressive and the others are probably not being aggressive enough. I think it's all about the patient. I think if we had a perfect way of knowing which patients did not have occult metastatic disease, we should go to any length necessary to get that tumor out. The problem is we don't really have that perfect ability yet. Or ever. But surgeons are going to some pretty extensive lengths to get tumors out now. Mm-hmm. And I'm not saying it's inappropriate. I just think it has to be matched to the patient.
Yeah. And I guess I'll ask you the same question. We briefly talked about the conventional radiotherapy, chemoradiation. Are we not being aggressive enough with radiation therapy? Should we use dose intensification like SBRT?
Yeah, so that's a great point, and certainly the hot topic in radiation treatment for pancreatic cancer. So I guess to start, a lot of people do use these synonymously, so dose escalation and SBRT. Technically, you can do one without the other and vice versa. So some of the original dose escalation data from Sloan Kettering, they actually did 25 fractions of radiation and just pushed the dose really high in those 25 fractions. But most people, when they're doing dose escalation, they will do it with SBRT. So what's the difference between SBRT and chemoradiation, right? SBRT uses much higher doses each treatment, the fraction size. And as a result, you can deliver the radiation in much fewer treatments, 5 or less treatments. Usually in pancreatic cancer, it's 5 treatments. And the way you do that is by being more precise with your treatment planning, with your respiratory motion management, with your onboard imaging, in order to deliver that safely and really just get the dose to the tumor and keep it away from your nearby organs at risk, which most of the time in pancreas cancer, it's the duodenum. That's the main thing that you have the potential to injure with high-dose radiation therapy. So SBRT, you do things like get a 4D CT simulation, which is where you oversample the patient throughout the respiratory cycle, and you can actually create an image of how the tumor moves up and down with expiration and inhalation, and then account for that during the treatment planning process to cover the entire length that it moves, or sometimes we do something called respiratory gating, where we treat at certain phases of the breathing cycle and then turn the beam off when the tumor moves out of the target volume, and then turn it back on. And going along with that, another motion management strategy is breath hold treatments, which we use during diagnostic scans, so patients are often familiar with it, where they take a deep breath and they hold it during the treatment, and then that, obviously minimizes any respiratory motion. They have to be able to hold their breath a fair number of times, probably 20, 30 times over the course of each treatment, so it's not for everybody. But these are the advancements in technologies over the past 10 or 15 years that have sort of enabled that interest in dose escalation. So some of the early studies of pancreas SBRT, there were pretty high rates of serious toxicity, duodenal bleeding, fibrosis, that sort of thing. And it's getting a lot safer in the past 10 or so years because of these technological advancements. Another one that has often been used in studies is the MR-Linac, so delivering your treatments based on images from an MRI, which gives you better, as we talked about earlier, better soft tissue contrast, right? Better delineation between tumor, duodenum, normal pancreas, vessels. And so some of the really promising data that's come out uses MR-guided Linacs. But even on CT-guided Linacs, standard run-of-the-mill linear accelerators, people are getting up to 50 gray in 5 fractions, which we think of as that sort of ablative dose, much more safely than we used to. And the initial data has been really encouraging.
So I guess that leads perfectly into the next question is, how do you choose between the two? And what does, obviously, if you say the field is moving more towards SBRT, is that because you have better local control? Is it better survivability, et cetera?
So, yeah, I think a lot of people hope there are better local control and or survivability with SBRT. That's not yet been proven. So there's a phase 3 randomized study through the NRG right now in locally advanced pancreatic cancer that we have open at UCSD that is looking at this. It's randomizing people to sort of conventional low-dose radiation versus dose-escalated SBRT. for unresectable pancreatic cancer after chemo, still unresectable. And so we as a field are very excited about that. And yes, I hope it will improve survival. But even if it doesn't, right? One thing I think about is time, right? Unfortunately, the median survival on most of these studies is a year and a half, right? And if you do chemorads for a month, that might be 10% of someone's remaining life that they're coming in and out of your department every day for radiation treatments versus SBRT is done in 5 days. So it's a lot more convenient for patients and possibly more effective. So I think so back to where you started your question, which is how do you decide between them? I think for patients who are clearly not going to surgery, we lean heavily toward SBRT and dose escalated SBRT, as much as feasibly possible. For patients where surgery is still potentially on the table, we lean a little more towards the fractionated 5 weeks of chemoradiation.
And would you say there's equipoise throughout the entire nation here on that same, or do you think that the jury's still out? Do most people practice like that, or is that unique to us?
I think if anything, even at high volume centers, that it's shifting more and more towards SBRT. There are plenty of leading institutions that do SBRT almost exclusively, even in the pre-op setting. Mm-hmm. And there's some mixed data about that, and clearly one has not been proven to be better than the other, or we would all just adopt that. So it's very controversial. It's very institution dependent. But if anything, over time, I would say it's trending towards more SBRT and less fractionated.
Interesting. So we've, I think, beaten both surgery and radiation to death. There are other therapies you may read about or see online being talked about. So what other sorts of local therapies are offered out there, and what sort of evidence do we have for them?
Right. So you mentioned the word ablative dose of radiation. So ablation is any treatment where you're killing a tumor rather than removing it. So most people don't think of radiation as an ablative as a form of ablation, but it can be. Mm-hmm. But the more traditional forms of ablation include thermal ablation, as you know, with radiofrequency or microwave ablation, or with cold, like cryoablation. And I think although these have been tried in the pancreas, basically they have not been extremely effective. In fact, there was a recently published large randomized trial from Europe with RFA, the Pelican trial, that was definitively negative. And in fact, the RFA patients did worse. So I think the forms of ablation that have had better traction in pancreas cancer are using electricity, so electroporation or irreversible electroporation. We call it IRE. A lot of patients and providers know it as NanoKnife. That's just the brand name that make the most common generator for IRE. Of course, we have a lot of experience with IRE at UCSD, so I'm a little bit biased, but I will just mention that the other form of ablation that's out there is histotripsy, which has, I think, much less experience with that in pancreas, but there are definitely people who are studying it.
Yeah. So let's talk about IRE, because I think that has the most exciting prospective data so far.
Yeah.
So briefly, how does IRE work and what's the mechanism of?
So I think most people remember that when you treat cells with current, it pokes holes in the membrane and you can use it to deliver stuff into cells. But if you do it too much, the cells die. And so that's the idea behind irreversible electroporation. And so as a clinical ablation modality, we are basically placing long needles, we call them probes, to bracket the tumor, and then we deliver a current across the tumor. And the dose it's a function of the number of pulses, the voltage, the length of the pulse. And if you go too much, you get into that thermal range, and you can basically have a thermal ablation. Or if you don't do it enough, the cells will recover, and you can have recurrence. And so it's technically it does require a lot of precision, and the probe placement is key. So in the United States, most people have done IRE using a surgical approach, and so I think this gives you perhaps the most flexibility in getting your probes into the right place. That's how we have largely performed it at UCSD. In Europe, IRE is mostly performed percutaneously using CT guidance. And of course, the appeal of that is that it's less invasive, and you can also better integrates the CT for the probe guidance, and it's easier to do it more than once if needed. But overall, I'd say the outcomes with percutaneous IRE have not been quite as good as with surgical IRE, but that may just be a function. That may just be patient selection. That the fitter patients are getting surgical IRE.
Yeah. So what data is out there for IRE?
So I would say we don't have any level 1 evidence. I mean, there are lots of both prospective and retrospective studies showing that IRE can be done, that it's reasonably safe. I mean, it is pancreas surgery, so it does have complications that are comparable to pancreas surgery. It's been pretty effective at local control with local control rates close to 100% in some of the series. But just as with pancreas resection, the problem is always distant recurrence. And so I think that's why there has been a lot of interest in trying to combine ablative therapies like IRE with different forms of immunotherapy to see if we can defeat those systemic recurrences. And that's an area that we are very much interested in.
Yeah, I think that's like kind of the holy grail, right?
Yes.
It's getting any immunotherapy has revolutionized most malignancies out there, right? At least solid tumor malignancies, but really has struggled to gain traction in pancreatic cancer.
We have no FDA-approved immunotherapies in pancreatic cancer, other than that tiny percentage of patients that have DNA repair deficiencies.
Yeah. And recently we've seen a lot more of intra-arterial infusions.
Mm-hmm.
I don't know what your guys' experience or what your knowledge have you seen this, and particularly I think the dual balloon occlusion with intra-arterial gemcitabine gained some traction. They've talked a lot about that post-radiation, so I don't know what your thoughts are on that.
Yeah, that's an interesting emerging, also I would say very early stage technique, but it is interesting, and it does make some sense that we know radiation alters vasculature within tumors, and the fact that might enhance a local drug delivery and those would synergize together makes a lot of sense, and that is what is seen in the small sets of data that are available, that radiation treatment prior to that local chemotherapy delivery can sort of enhance its effectiveness. So I think that's an interesting avenue. The other, treatment that we haven't touched on that's probably worth mentioning is tumor treating fields. There was some data presenting at ASCO last year, and as a radiation oncologist, I know these pretty well from GBM, but it was very small. It was like a median 1 month overall survival benefit, but it was a benefit with Gemabraxane chemotherapy.
So what are tumor treating fields?
Tumor treating fields are this device that you wear over the area of the abdomen. You have to wear it. They want you to wear it at least 18 hours a day. So you have to wear it pretty much the whole time. And it sends magnetic fields back and forth over that area, which disrupts mitosis, is my understanding of the scientific mechanism there. So yeah, there is some overall survival advantage in GBM, and now we've seen that in pancreas cancer as well. So that's another option for somebody with locally advanced disease, not amenable to surgery, right? When they're thinking about these pathways.
And I guess the elephant in the room of any pancreatic discussion right now, at least in 2026, is the use of RAS inhibitors.
Mm-hmm.
Yeah. Where do RAS inhibitors stand? At least the trials that are open right now for locally advanced pancreatic cancer.
I think that's an area that is ripe for exploration, especially with the data that's come out just this week with RAS inhibitors in the metastatic setting having a survival benefit over chemo. So yeah, I know that's something that we'll be looking at UCSD, is getting trials open in the neoadjuvant space. Maybe, as Becky said earlier, the conversion rates to surgery for locally advanced patients, optimistically 30-40%. Most people never make it to surgery. And so that's a huge opportunity to potentially cure more patients if we can get more people converted to borderline and resectable disease. And I'm very excited to see where that goes.
I think what's especially exciting is some preclinical evidence that it can be synergistic with immunotherapy, and so I know there are some trials ongoing to evaluate combinations of KRAS inhibitors with checkpoint inhibitors. So
yeah, so I guess that kind of segues nicely into our last topic right here is in the next 5 to 10 years, what sort of big advancements do you guys hope to see in the field? Is it, like you said, better targeting with the radiation therapy? Is it getting immunotherapy, which is always an elusive target? Is it better surgical techniques? What do you guys foresee in 2036 being the standard of care for locally advanced pancreatic cancer?
I think for me, the big opportunity as a radiation oncologist, yes, I want to convert more people to resectable disease, whether that's with RAS inhibitors, immunotherapy. But the outcomes are so dismal right now without surgery. And can we move that needle with SBRT? We've talked a lot about the dose escalation aspect of that. The other big trend that doesn't have any randomized evidence behind it is the volumes are changing. So the early pancreas SBRT series, you just treat the tumor itself with a little bit of margin. And looking back at those, there are a lot of failures sort of on the margin or just beyond or right up by the celiac axis. And so the other trend that's been coming in is elective volumes at a lower dose. It's not as high as the dose to the main pancreatic mass, but we treat what we call the triangle volume. So the celiac axis, the SMA, and the portal vein, and the kind of space between those, because that's where the vast majority of those local regional failures are. And so there's some very promising data that as well can improve outcomes for people who don't make it to surgery. So I'm hopeful that'll be a component of our treatment 10 years down the road.
And I think what I want to see in the next 5 to 10 years is more personalization. I think, we're starting to get there. We have a few biomarkers that can guide therapy, but we know there are huge differences in people's sensitivity to radiation, for example, and in their sensitivity to different chemo agents. And so I think we're going to, I sort of said that I dismiss ctDNA as not being ready for prime time. That's not true, but I think we'll start seeing more use of that even in the localized disease setting, where we can get information about someone's tumor, either from their tumor or perhaps from their blood, and be able to say, this is going to be the right treatment for you.
I think that is a perfect place to stop. So thank you so much for this actually quite lively discussion. And hopefully in 10 years, we can come back and do it again and repeat this.
Thanks for having us.
Thanks.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.